I'm a medical officer in the hospital Kuala Lumpur Emergency Department, and today I'll be presenting a case, the title Big Arm, Big Problem. So basically, this patient came to us complaining of big arm. So when he came to us, basically the case description is he's a 37 years old Indian male with no known comorbids. He came to us about a week prior with complaints of left upper limb swelling and pain. And prior to that, on the onset of illness itself, he came and was treated for cellulitis and was discharged home with a course of cloxacillin for a week. However, symptoms did not improve, and patient came back to us for symptoms review. And this is actually an actual picture of the patient. Okay. Besides that, on further questioning, patient complains that he has a history of body massage 2 weeks prior to onset, and a week later he started developing pleuritic chest pain and pain over the posterior aspect of the left arm, which spontaneous a day after that. For the history, he only says that he has a history of trauma about 14 years ago, in which he sustained query left radius fracture. There was no recent history of trauma, no insect bites, or any history of taking any traditional medications. Patient was well and active prior to the illness, and he works as a taxi driver. So he's been saying that this problem that he has with the big arm, it's affecting his daily activities. So on examination, there was a swollen left upper limb from the proximal arm to the hand with pitting edema, and it was slightly erythematous, tender, and there was slight increase in warmth. And the distal pulses are all palpable with the capillary release time of 1 second, and other systemic examination was unremarkable. So you can see there was a marked difference between the left and the right hand. So the affected hand is on the left side. And this is the side view of the patient. The left upper limb shows a significantly larger compared to the right upper limb. So in our emergency department, we proceeded with ultrasound, which shows a non-compressible left internal jugular vein and left axillary vein. And at that point of time, the diagnosis of an extensive left upper limb DVT was made, and patient was served with Clexane and admitted to the ward for anticoagulation therapy. During the admission to the ward, a formal ultrasound Doppler of the left upper limb was done. It was shown that there was no Doppler signal and flow seen within the left axillary, left basilic, and up to the left forearm, and also the left brachial veins. The vessels are all not compressible, and there was no obvious intraluminal echogenicity seen. So the impression given at that time was in keeping with a long segment thrombus of the left upper limb veins. Patient remained stable throughout the admission. However, investigation for hypercoagulable states was not taken in view of initiation of anticoagulation therapy earlier on. So the bloods that were taken, there was not the protein C, protein Z, the protein S was not taken. Patient was then started on warfarin and was discharged home 3 weeks later with a follow-up at the physician's clinic. Patient was actually admitted for 3 weeks as he was found out to have incidental finding of hypertension. His blood pressure remains high throughout the admission. It was ranging between 170 to 180 over 80 over 90, 80 to 90. He was started on multiple antihypertensive, and subsequently the BP became lower and was discharged home after that. However, I could not find what happened after that because the notes from the physician's clinic is not available. Okay, so we go to the discussion part. So upper limb DVT is not a common diagnosis compared to lower limb DVT. And recently, the clinical importance of upper limb DVT has increased tremendously in view of first the advancements in imaging modalities. And another thing is that there is a wide usage of central venous catheter, in which has predisposed patients to have an upper extreme deep vein thrombosis. And in most cases that was studied, upper limb DVT comprises about 2% of all deep venous limb thrombosis. So there are the causes of upper extreme DVTs can be divided into two. It's either the primary or the secondary cause. And the primary causes was studied by Dr. Paget and Dr. Schroeter, and it was called Paget-Schroeter syndrome, in which they discovered that these types of upper extreme DVTs are usually occurred after there was after there's a strenuous activity of the upper limb, and it's also known as an effort thrombosis. Usually what happens in this kind of patient, they have a certain compressive anatomy at the thoracic outlet that is disturbing the Virchow's triad, the hypercoagulable state, the viscosity, and also the thrombosis. Okay, and then the secondary causes are usually seen in patients with multiple comorbids. For example, patient who has indwelling central venous catheters, patient with pacemaker, and malignancy. And in the secondary causes of upper extreme DVTs, the morbidity and mortality is higher compared to the primary ones. And the primary ones are usually curable and has a better prognosis. Okay, in most of the studies that are being studied, it is seen that the predisposing factors that are usually commonly seen are mainly malignancy, which comes first. Then there are patients who has post-operative or trauma, and patients who are obese with BMI of more than 30. And in this patient, some of them have an associated current of previous indwelling lines. So in this patient, the most likely cause of DVT could be a primary upper extreme DVT, as he has a positive history of rigorous activity in which he went for a rigorous body massage for about 2 weeks prior to the onset of illness, and there was no other risk factors that was seen. And in most cases that was also studied, the main presenting complaints are pain and edema. However, there are in certain cases, it was seen that the diagnosis of upper extreme DVT was only made after they presented with a complication of deep vein thrombosis, for example, pulmonary embolism, and also post-thrombotic sequelae. In post-thrombotic sequelae, usually the patient would present with pain, swelling, and they started developing venous ulcer, varicose vein, and others. And there are studies that discuss on the main modalities of imaging that can really help in diagnosing upper extreme deep vein thrombosis. So it was studied that the most commonly used is ultrasound, and has been proven that ultrasound itself is enough and sufficient to make this diagnosis. Other imaging modalities that can be used includes your MRIs and CT scans. And the main therapeutic treatment for deep vein thrombosis remains the anticoagulation therapy to prevent thrombus formation and also pulmonary embolism. There are, in some extreme cases, it was shown that besides thrombolysis, besides anticoagulation, they use thrombolysis, they use streptokinase, and there was also cases that use thrombectomy and SVC filters, and in some extreme cases and also recurring cases, they use surgical intervention. So, lesson learned. So, the diagnosis of upper limb DVT is not common and may be missed easily. And in this patient, when the patient come initially to our department, we thought that it is just a simple case of cellulitis, and so we discharged him home with a course of antibiotic, which was not resolving. So it's good enough that the patient came back to us in our follow-up clinic and to have his symptoms reviewed. And usually, upper limb DVT, it is associated with higher mortality and morbidity if not treated earlier, because the percentage of people developing pulmonary embolism compared to pulmonary embolism in cases of upper extreme DVTs compared to the lower limb is higher. And the diagnosis may be missed in patient who presents with either infective symptoms or even in trauma cases. And in this case, the use of bedside ultrasound has aided in making the diagnosis. A simple bedside ultrasound was adequate in making the diagnosis, and then the patient was treated earlier and was then admitted to the ward for continuation of therapy. So these are my references. With this, my presentation.
Thank you. Maybe I would like the Focus Malaysia to comment first.
I think representing is something that's right, but it's something that probably important if we actually managing patient with possible pulmonary embolism, DVT actually, because it's common. The most commonest people is actually we tend to neglect the upper limb contribution into pulmonary embolism, formation of thrombus, etc. I can't remember the exact percentage. I think it's less than 3%. I think so. Okay, but the thing is, normally when we see a thrombus in, for example, in DVT, normally we're not going to stop at that. Then we're going to proceed the possibility of other thrombus that will form somewhere in a supravenous cava or inferior vena cava. Okay, I start talking now. Okay, in right atrium, etc. Okay, so it's the number one. Number two, I think diagnosing DVT in upper limb need what I call it more form of monitoring, because of the high possibility this patient start presented with a pulmonary embolism. Right? So we don't tend to underestimate this kind of diagnosis. Thank you.
Maybe Prof. Maligan for the next comment.
So now we have a condition that we often diagnose by an ultra-specific assay, the D-dimer, right? So again, this is 2% of the time you're going to see a DVT in the upper extremity, which is 1 out of 50 DVTs. How many DVTs have you seen in your career? You're probably going to see one. Okay, so you always have to have a high degree of suspicion. Any kind of swelling, any kind of redness. How often do DVTs present like the classical presentation of DVT? About a third of the time, which means why are they calling it classical? They should call it something else. But again, it's a high degree of suspicion. What else can this be? What's the other diagnosis? And we always have to think about life and limb-threatening conditions in somebody who comes in with an obvious clinical abnormality like what we saw in the picture. So good presentation and good discussion of the outcomes.
All right. Dr. Ranjin.
Okay, thank you for presenting a green zone case. We tend to concentrate so much on the red zones, which is like very clear cut that something very alarming is happening. Huh? So yeah, in fact, you can see that the patient presented twice, and the first time it was missed, and second time it was picked up. It was very good picked up. It was really amazing. Just from the MO itself, getting the specialists involved, these kind of things, yeah, do tend to just slip through the cracks. By any chance, did the massage contribute to the formation?
We were thinking about it now because there was no other risk factors involved. The patient is very well and active prior to that, and he said that the massage that he went through was quite a rigorous one. So maybe that's predisposing factors. Yeah.
Okay, thank you very much, Dr. Hazwani. The last presentation will be